can say the, now once I have cut the, you can say the uh, capsule, there is a lens, and in that now I want to do the phacoemulsification. So what you feel, what is to be done now? Because he will convert it to the SICS as the posterior capsule is very weak, or he will do something, what he will do in this situation. So what do you feel? हाँ, माइक दे सकते हो, एक जरा माइक दे सकते हो, माइक चालू करो ना, आप बैठ के बैठे बात करो, माइक चालू करो, नहीं आवाज़ नहीं आ रहा, हाँ.
In this case, the rhexis is not regular and there is no support, cortical support. So phaco is difficult for me. And also our nucleus is very mobile. So if only expert surgeon can do, for beginners and novice surgeon it is very difficult.
Very
for
true.
For me, I can go for SICS.
Convert.
Because I am expert in SICS, so I can go for SICS. Or otherwise, go for ECC. By giving the big incision, so we will put less pressure over the zonule and other, so it will give good result.
Correct. So basically what happens ki when the there is no any buttress, it means no epinucleus, no cortex. The nucleus is a wandering nucleus, and in this wandering nucleus, then I totally agree, because in such situation, basically you can extend and you can remove the lens, and that is, I think that is the safest, because here nothing is going to happen. But if, as you said, if you are an expert, this one, phacosurgeon, then what can you do? And so, can you do the phacoemulsification? Yes. So you can go for the IOL scaffold, and after doing the IOL scaffold, now. Yes. Basically the, as it is a bag is there, though irregular bag, the though the bag is there, irregular bag is there, but capsule is fibrous capsule. So what madam said is very true, that you can use the IOL scaffold as a support for the doing phacoemulsification, because if that support is there, then it is possible to do the phacoemulsification. Now see the how this case was managed. हाँ, ये इधर नहीं दिख रहा है, ये यहाँ नहीं दिख रहा है. हाँ. So now this case you will see, like madam has very rightly, it means 100% rightly said, that you put a IOL scaffold, and this should be at the iris level. You will see the haptics are kept on the iris, and after that the phacoemulsification is done. Yes, and I will see the how I am doing the chop, how I am doing the chop. You will see there is no any buttress, nothing is there, and you will see this how I am doing the phacoemulsification, and see what happens in this. I am doing in the pupillary zone, and when I am doing in the pupillary zone, see here the most important thing is that rhexis is most difficult part of the surgery, that we are done by the, you can say, cutting and all other things. Now it can be very well used in the weak support, or you can say the cortical support for the nucleus during the cataract removal. And the Morganian cataract is small and hard nucleus. Nucleus is very harder one, and so in such situation the scaffold technique definitely helps us, and that will always can see will do the such type of surgery. So this is what and then the I will go to the other, and then Ragini will present two cases, and then I will present another cases, as Sumit has not came. Now see this another case. see here, I am doing this case. You will see the I am rotating the nucleus. I am trying to do the phacoemulsification. So once you are trying to do the phacoemulsification and your plane, you have not succeeded in the plane. It means if you are not succeeded in the plane, then you had it. It means now what has happened? There are haphazard, all the can say the trains, 1 trains, 2 trains, 3 trains, 4 trains, it has happened. Now these when these trains are happened, so what happens? Why these trains are happened? Because that time it has not thought that what is going to happen and where the cataract is more thicker and harder and where cataract is not thicker and harder. And because of that you will see what happens, the lens, you will see this in this this lens diaphragm, this iris diaphragm is coming forward. You can see here it is just moving, iris is moving, coming forward, and I am trying everything, but because of the iris movement it is very difficult to do the phacoemulsification. So whenever such thing happens, then in this situation, basic thing, what will you do? I want to ask the Ragini here, or 1 minute. Now see what has happened. You have seen the iris was, pupil was becoming smaller, pupil was becoming larger. And because of that, the phacoemulsification was very difficult. So I want madam to tell madam what you will think in such situation. Very correct. Only one thing required is reduce the parameter. Reduce all. It means basically you reduce the vacuum. You reduce the vacuum. Vacuum was 600 there when it was done. So you reduce the vacuum. Once you have reduced the vacuum, then reduce all other parameters so that the inside. So this is one type of surge which is happening because of the iris. You can see iris is coming and going forward, and because of that, it is very difficult to take the nucleus. This one. Why? Because you are afraid of the iris. The iris is just coming and pupil is becoming smaller, and this the iris repulsion syndrome. Basically, think once it is happening on the first time only, stop it, put visco, go to the machine setting, reduce the machine setting half, completely half. Every machine setting should be half, and then you should go ahead. And if you do that, then it is possible in the iris repulsion syndrome you can do such type of surgery, and so then you can complete the surgery. And see this, the only thing is all the fluid dynamics should be low, like madam has said very rightly. There are all the fluid dynamics, if it is those are the low fluid dynamics, then it is possible to tackle such type of situation, and if not, then it is yes madam.
Sir, in such case, in the mid-way, it is very difficult to convert to SICS.
Yes, ma'am. Yes, ma'am.
You are unable to remove the nucleus from the bag.
Yes,
So
ma'am.
it is the phaco probe that only can remove.
Very correct. Because here, like the previous case where we were thinking of SICS, but in iris diaphragm syndrome, what happens? This iris repulsion syndrome, as madam very rightly said, you cannot remove the nucleus, and that nucleus will not come out because of this iris activity. And for that, SICS will be again more difficult, because every time if you will do SICS, what will happen? The iris will come and not the nucleus. And then you can know the once iris is coming, then iris pigmentation, then you can say aerodialysis, tears in the iris, so many things happens. So it is better to keep iris there only. If the iris is coming out of the wound, that is the major problem happens in iris repulsion syndrome. And so to avoid the iris repulsion syndrome, in the SICS we should not try. We should try only the, you can say, low phaco powers, low vacuum, everything low. And in that, another thing is the surgeon should be low. Here the surgeon should not be a fast surgeon. If the surgeon is fast surgeon, he will definitely do the phacoemulsification, but in the vitreous, not in the anterior chamber, the lens will be in the vitreous, and then he will have to just call the, you can say, the retina surgeon, and that retina surgeon will then help him. So it is always better to do the surgery, and you have seen the surgery. I have completed this. Now I will ask Dr. Ragini to present two cases, and then I will present another cases. Ragini, come.
Thank you, sir. So this is a patient who has a bilateral cataract. As you can see, it is hypermature. The capsule is stained, and we are trying to do the rexes with the Utratas forceps. And you can see that there is subluxation of the lens, and this is difficult to do the rexes. When we try to do the rexes, the whole nucleus is lifted up. So as we can see, if this is happening, so what will you do? And this patient is a young patient with subluxation, like a like a spherophakic lens, and the capsule is so elastic because the patient is young, and every time you try to do it with a needle, it was not possible. So if you try to do with the rexes also, as forceps also, as we can see, the whole nucleus was moving. So what is to be done?
First, we have to use the high molecular weight
Viscoelastic.
And the idea to do the capsulosis is we have to stabilize the both pressure, posterior pressure and anterior pressure. So we have to look what is
How can we
yes.
put the lens down,
The speculum, any conjunctival swelling.
which is causing the pressure?
Yes, that's very important.
Yes. So like,
any other person who wants in this, as Madam has told me, you can go
All
for
very good.
no ma'am, no ma'am, you are,
I think
whatever
you
you
are
have
right.
said so far, everything is correctly scientific, so anybody wants to talk, they will talk, but it is good that you are, and as you saw that you have, for all the cases, you've rightly given the correct way.
Same problem.
Yes.
If you have faced the problem, you know better.
Yes. So these are the day-to-day problems, because everybody is operating, even the students are operating. So these are day-to-day problems that we see. So exactly. So either the nucleus can be aspirated. Now, as we can see over here, you cannot hold on to the capsule because the capsule is very, very elastic. So what we do is that this is a young patient, so what was required was only aspiration, and then the IOL, and like we said that, like Madam said, that we had to fill it with viscoelastic and then go ahead and then put in the IOL. Now once this is in the bag, you can fashion it into a rexis sort of. So here we are aspirating, putting in the IOL. So here, because we know that there is a bag, either a 3-piece or a 1-piece lens can be put. If we are putting it in the bag, then it would be a 3-piece lens, or otherwise a 1-piece lens.
Now in this, madam, as you are saying, it is a, now the IOL is in the bag. So here you will advise 3-piece IOL, or you will advise the 1-piece?
The 3 piece.
3-piece.
Because see, the capsule is not having the straight head, as the capsule is broken, and the capsule is broken, because of that it is always better that 3-piece IOL will help, and this is like a CTI, so that 3-piece IOL will work as a CTI, and other thing is that IOL will not move. It means the IOL will be there, and that will be good.
No rotation.
No rotations of the IOL will be there. So I think 3-piece IOL will be better.
So we,
Yeah. Yes, yes. The fibrosis, if you go for the single piece, very true, because the fibrosis will be more, and I think the lens will, because of that, it will come on one side. Because on
So we welcome Dr. Piyush Goel, who is one of the scientific committee members, and
Come. Please come. Piyush is a scientific committee member and now he is the scientific committee chairman of Maharashtra. Just now got elected. I congratulate him, Piyush. Please sit. Go ahead.
no, I was reducing the volume. So this is a patient which is already subluxated, which you can see over here, and here we are putting in a CTR ring because the subluxation is very big, and then
See what happens. Now you have seen there is a subluxation. But can you see the subluxation? Subluxation is from, you can say, the near about from the 3 o'clock position to the other side. It is near about, you can say, 8, 9.
4 clock hours at
4
least.
o'clock. So it is more than the, so it is more than, can say, in the purview of CTR. But we have put a CTR. And after the CTR, what will you feel? Is it possible now, after putting and stabilizing the capsule, can you now do the phacoemulsification now? So always, you are very correct. See what happens here. I was doing this case. I also, I was also doing this case, and I thought, why I put a CTR? Because I thought after putting the CTR, I will be able to do the phacoemulsification. But once we read so many things, and when you can say it is more than 4 o'clock position, that you can say the subluxation. In such situation, the phaco power and the what we are doing, that phaco power, this CTR will not withstand, and that will cause the problem. Slightly go ahead.
Go ahead.
Chalu kar. Now see here, I am doing, but what is happening? The lens, can you see the lens is coming out and going back. So now in this situation, when the lens is coming out and going back, what will you do, madam? Again you reduce the one. Very correct. Second. Any other?
You will. Yes.
Capsule hook. Very true. So you have to put the stabilize the rexis. Stabilize the rexis, and once you stabilize the rexis, then it is possible that you can do the phacoemulsification. But if you are not having the capsular hook, you are operating, then what will you do? Yes, then iris hook can be used. And so every time we should not be an ideal thing. What we should see the result. And for the result, now go ahead. So madam has, see, we have got very practical experience. Put a capsular stabilizer device and see here now. What I am doing, I am stabilizing, but this is a iris hook. This is not capsular hook, because in my armamentarium that time in my OT it is not there. And so I have put a iris hook. And once I have put a iris hook, you will see now how I am doing. Now again you will see what madam has told. The parameters are reduced. The parameters here are reduced. And these reduced parameters, can you see this? The reduced parameters, here you will see. The reduced parameters, and in these reduced parameters, I am doing, see, you have seen the phacoemulsification before, but here I am doing it, I am by reducing the parameters. Yes, Ragini.
So all type of cases are possible. Only thing is that you should have all these things in the OT. You have to be careful, and before starting a patient of subluxation, you have to have all these ready in the OT. You should know what will you need. Patient has to be counseled. Triamcinolone should be there because they may be vitreous. Secondary IOL such as iris cloth, 3-piece or scleral fixated lenses should be kept standby. And when you are doing the rexes, it should be centered on the lens and not as per pupil. Because later when you center or stabilize the back, then your centration will be different. So I think that these are very practical aspects which everybody...
Yes.
ASIA anchor. Dr. Asia from Israel has device, like how we have these the segments or the Ahmad segments or this. So similarly, that's a device.
That
The
a device.
name, the name is ASSIA, ASSIA. The
T-shape. It's a T-shape device. Asia. I was with Asia for 3 months in 1996 in Israel. So he was devised this. It is a T-shape. Like that you see the C-shaped or like that. It's a T-shaped device. He has devised. Just so now again the go to the sometimes what happens whenever we are doing the our surgery, and in that you have done surgery in one patient and you have come across some complication. When you are doing another patient, that previous patient will teach you. When you did that in such cases, then you were wrong that time. And so what happens, I always say that my mistake teach me. It means whatever the mistake I have made, but what happens when I will accept my mistake, then only those mistakes will teach me. But if I will not accept the mistake, how those mistakes will teach me? So that will never teach you. So what I am presenting here is my mistakes. This is not my resident. This is my mistakes, and how my mistakes has taught me when I was doing the other cases or the same case. Now see my mistakes, my lessons. So now see here, I am doing the phacoemulsification. You can see here, I am doing it. Can you see this? I am doing it, phacoemulsification. And yes, I am just, you can say cataract is a grade 2 cataract, and I am doing it. But once I have finished, you will see there is a PC tear. So when I have seen that there is a PC tear, then when I was doing the phacoemulsification, I have not seen it has happened. Means I was doing the phacoemulsification continuously. But when I came to the last piece, I came to know there is a PC tear. Before that, I have not came to know the PC tear. So why? Two things. One is, I have not noticed there is PC tear. One. Secondly, vitreous has not came because there is a small PC tear. Thirdly, PC has not gone behind. Or if it has gone, I have not seen. Fourthly, when I was doing this, I have not seen properly. Now why this has happened? Why there was a PC tear? So PC tear, is that it means it is because of me, because of machine, because of patient. So anything goes wrong, we will say there was a posterior capsular defect. But now there is a OCT, and because of OCT we can see the posterior capsular defect before operating. So now what happened? What went wrong? I will show you. Now see here. See what I am doing is, see here. So can you see this? What has happened? Now, yes, I was trenching, and during trenching only can you see this? Now why this has happened? Because we always talk, teach, learn that your phaco tip should be in the center. Phaco tip should be in the 6 millimeter. And if it is not in the 6 millimeter, what happens? So this is what has happened. The PC has teared, and teared by me. Why I have teared? Because I have crossed the border of safety. Border of safety, or you can say circle of safety, is 6 millimeter of the nucleus. Yes, madam. Yes, up. Yes.
because the nucleus is like this, so here if you do not
see, nucleus is thicker, that is 4.5 millimeter in the center. As you go in the periphery, that is a 2.5 millimeter. So once there is a 2 millimeter difference, if you are going in the same line, what will happen? That is going to be teared. Second thing is, if you are not going like this, it is going to be teared. And thirdly, you remain inside the 4.5 millimeter depth, means 6 millimeter. The 6 millimeter is a line of circle. In that safety, you must work and you can go deep. Here you can go deep more also. Why? Because your phaco tip will not go more than 4 millimeter. Because your tip is not entered only, and because of that you will not tear the PC. So, the lesson learned, or what we can learn from this is, see now, where my phaco tip is there, where it is. So much away from the, you can say this has entered there, and so this has happened. So always better to be in the circle of safety, and then the अरे एक मिनट 1 minute, हाँ 1 minute, I will go back. हाँ 1 this is in the please in the soft cataract. Now what happens in the soft cataract, when the cataract is very soft, basically when you are trenching, in the trenching, when you have reached proper depth, how you will understand, I will tell you. When you see the glow, the glow in the soft cataract is seen. But when the particular thickness, means how much, 2/3 thickness of the nucleus is trenched out, the glow in the center shines. Glow in the center shines in the soft cataract also. Why? Because at other place, glow is seen through the cataract. Glow is seen through the cataract, and here you have cut the cataract, and because of that, glow is more there, and that is the depth where you should stop. You should stop. But if you are going again down, then there will be a chance of the, you can say. So now this is the another case. हाँ, इसको मैं फिनिश करना चाहता हूँ. हाँ, so I was to see now what I have done. See here. So where it is near the iris. Can you see this? Now what I am doing is, I am doing the vitrectomy. So always remember, when you come to know that you have done the vitrectomy, after that you can put this, now see here, it's a fibrous lens. See, I am doing the rhexis, and what is happening? Nucleus is moving. Why? Capsule is thicker, fibrous capsule. Now only who can support you here? For doing the rhexis, who can support you here? See, can forceps support? Yes, forceps can support partially. But how forceps will support? When there is a fibrous, where there is a fibrous capsule, where there is a fibrous capsule, that capsule will not be teared by the forceps also, not the forceps also. Why? Because that is fibrous capsule. Femtosecond, yes, you can do, but we are ordinary persons, so nobody has the femtosecond. Now what we can do is, we must know that where is the fibrosis is there. If the fibrosis is beyond and you can't see, then in that situation, do a small rhexis. Do a small rhexis and cut the capsule. But if you can see that it is in front of the pupil, then you can do the rhexis. Though it is extended, and though it is irregular. So it is not possible in the fibrous cataract to do the regular rhexis. Now here, see, I have tried first, there I was not able to do it. But later on, I did it from other side where there was no fibrosis. But I again entered in the fibrosis, and when I entered in the fibrosis, you can see, the rhexis is gone in the periphery. Rhexis is gone in the periphery. So now see here, can you see this? So I was doing the rhexis, I have started here, I was unable to do. Then I started here, and then the rhexis has gone here. That was not my plan. But automatically, because you will see this is the fibrous area. Can you see this is also fibrous area? So this is also fibrous area. So that is not going to listen to me. So that is what happens. And see now. See now. So I am trying to do it. Can you see this? Can you see this? I am trying to do it. What is happening? It is going in the periphery. Going in the periphery. See. See this. So here also, it means it was there just because of the fibrosis, the rhexis is irregular, and so here the risk of extension is so much. So you will have to be very cautious. Now see, this is what I am doing, the 1 minute. Now here you will see, this is me, it is not some other person. I am doing the phacoemulsification. What is happening? My phaco tip is moving. You see, my phaco tip, it is not. Now see, the phaco tip is moving. I am operating, see here, but my phaco tip is moving, and I am just trying to put the phaco tip inside, and you can see it is broken tip. So whenever you are going to do the phacoemulsification, lesson here, what is the lesson? What will you do? Anyone? Every phaco, when you are doing, you will see your sleeve is not teared. How outside you see it is a sleeve, yes, water is leaking or not. Secondly, you will again see by your hand tip, this finger, your tip, this phaco tip is correct or not. Yes, Raghav.
What you said is correct. So some days back we were operating a editor. Sir and sir was operating and I was assisting. So you know the wrenches that you get to tighten the phaco tip. So we use the disposable cassette. So that plastic wrench, they said it is not very good. You have to use a metal wrench to tighten. So in between, sir was thinking that phaco is not happening and all, and I thought there shouldn't be anything wrong. So we just came out and I told sir maybe the needle is loose. So it was not tight enough. Sometimes you get scared to tight, but even the wrench will be a problem, and the plastic wrench which came with the disposable cassette was not good, so you should have asked them for a metal wrench. So sometimes it is not your fault at all, and so everything, like sir said, your new sisters or somebody has to be trained to see that all these things are correctly placed or fitted.
Because this may cause a, yes ma'am.
Yes.
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 So it is very difficult to negotiate through that.
Very true.
Yes.
What madam said is very true, that 1 or 2 cases the sleeve is loose. My question is, why sleeve is loose? Can anybody answer? Why the sleeve is loose? Huh? Ah. So I want to tell you.
Multiple autoclaving.
No, it is not multiple autoclaving. The basic, it is, we'll have to, first of all, so we'll have to change every case. If not changing, why it is loose, I will tell you. So when you know the FECO, what is the FECO power? Here the ultrasonic power, when that piezoelectric things, it moves, the temperature of the tip. Do you know what is the temperature? Anybody can tell me what is the temperature of the tip? 1600 Fahrenheit is the temperature of the tip. So maximum infections are not happening because of the temperature of the tip. So that automatically gets trial. So I always say that whenever you are doing FECO, do slide FECO outside. It means what? You have sterilized your tip and then go inside. And because of that high temperature, whatever the ultrasound is working and the nucleus is melting, both are working, ultrasound and temperature, and that temperature causes the sleeve, loose sleeve. So whenever you are going in, that doesn't go in. So better, what is better thing? Change the sleeve for every patient. If there is a possibility, you have got the sleeves, you change it for every patient, and that will definitely help you when you are doing the phacoemulsification. Okay. It is, I will tell you. Now basically,
Needle, what we do is, since the needle is, the heat of the needle, it keeps it safe. So what, to escape this sister's meddling and all that, to remove the sleeve and put it in the set which is going away, and when you are getting a new set, तो वो सेट, जो सेट का ट्रे जा रहा है उसमें वो स्लीव डाल के, या व्हाट वी डू इज वेयर द फेको प्रोब इज, उसके जो पॉकेट में हम स्लीव डालते रहते हैं, सो दैट शी वोंट गिव इट टू अस. सो यू हैव टू बी सो केयरफुल. So there is a new sister, we have a new setup. So we were wanting to do post-operative dressing. The sister will cut the saline bottle with a scissor which is not sterile, and all sorts of things. So you have to be very careful with what they are doing and whether they are trained properly, because we may do everything but they may do anything. What you said is true.
Because assistants are very important, because phaco tape, you can say the needle, our sleeve, this is not our job. They do it. And when they do it, then all these things happens. Then
this we saw, no? The subluxated.
This we have seen. This we have seen. Now I go to the.
This phaco burn, you can say what is the cause of the phaco burn. Yes. So I used to, when I used to operate the post-operative day, no, second day, I used to always have this tunnel burns, and sir never had. So one day my sister was assisting him, and he told me that she always puts the sleeve in such a way that the needle is exposed quite a bit. So you have to put the sleeve close to the tip, but to be able to do phaco. So unless and until, I used to always wonder, am I doing something wrong? Why I am getting so much phaco burn? And when she assisted sir one day, the same thing happened, and he was observing. He said, you cover the needle tip more with the sleeve. These are such small things, na? Like, and then I stopped having tunnel burns post-operatively and all. So small things, and now that we are doing private and now we are doing topical, and even if not private, patients can see. So subconsumerage becomes a problem. vision next day with these IOL 66 N/6 they want and all that. So that, and forget what the patient wants. The burn means there is that much endothelial damage, so we also don't want it.
Okay. So now the other thing is, I am gradually going for the different cases. Now this is the, we always feel that we should do the hard cataract phacoemulsification, and that is what is always you can say the near to this one. Yes, every type of cataract I can tackle and I can remove. Now this is what is the hard cataract, but which hard cataract you should choose begin with. If you see this cataract, in the cataract there is a whitish appearance and then brownish appearance. If a cataract is having the whitish appearance and brownish appearance, such type of cataracts are easy cataract than the brown, or you can say the Brunson's cataract. So brown and Brunson's cataract, the glow is excellent, and because the glow is excellent, we see that cataract is easy one cataract. But when, always remember, when glow is excellent, that means there is a danger. In the nuclear cataract, if glow is excellent, there is a danger because there are leathery fibers behind. Those fibers are, you are unable to separate, and so to avoid, to learn white and brown cataract, choose white and brown cataract, and then you can go ahead and do, so that you will tune yourself. See now, this is the cataract I am doing. Can you see this? So here I am doing the chop. Can you see? Chop is possible here. See here again, can you see this? Can you see this? So I am doing the chop. Can you see my chopper and my tip, phaco tip here? Again you can see here my, can you see how that slanting tip is? The tip is behind, it is not in front. And see, then I can make the piece. It means when I am going, so in that my tip is slightly downward, not upward. And in that, now see again, can you see this? So here, then I am removing this. Now this is just you can see both debulking, the removal of the hard nucleus, and again now see this remained piece is there, that I have taken. So when that small piece is taken, in that, so see now, two small pieces are remained there. Now what precaution you will take when you have done such a hard cataract? Means what? You have used more power, you have used more phaco energy, you have used more aspiration, you have used more vacuum. It means your motor is in the speed of 120. It is because cataract was very hard, so your motor is in the 120. So what will you do? It means you will have to break the motor. And in the phacoemulsification, normally complications happens here because you are not breaking the speed here. Breaking the speed here. So can anybody tell me how much break you should do and when it should do? Which mode? Intelligent phaco, but what has happened, in every machine there is no intelligent phaco. That is the, see, we are considering, you can say, upper machine, or we are considering the small machines, because all those machines are there in that. Of course there are AI modes, but that is in Centurion. But in the non-Centurion machine, I will tell you how to. Once you are finishing third piece, on the fourth piece, before going to the last piece, if you have made 4, if you have made 5, 4 piece, then your speed should be reduced to half. Your speed, every speed should be reduced to half. The other question you will ask me that you will change the parameters? No. Your foot control should be the control of the parameters. your foot control should be the control of the parameters. And this, why? It is not for the any soft cataract. Remember, it is for the hypermature cataract and it is for the nuclear cataract. So in these cataracts, if this is your speed is not reduced, the surge is going to happen. Why? Because it is a nuclear cataract, no epinucleus, no buttress, and your motor speed is 120. So what will happen? Though you will remove the nucleus, the same time the vacuum where your tip is not with the nucleus, it means tip is slightly empty area. So that area will create a surge inside the anterior chamber, and then capsule will come up, and unknowingly you will tear the capsule. You will feel, I am sorry, wo ho gaya. But why it has happened? Because your nucleus was hard, and because of that you were using all the powers, and there you get the accident. See now, you see the how I am now seeing. So my this one is not moving only. Always remember, this is a posterior dense fibers are there, and so you will have to use more visco. If once or twice or thrice, why we should use the visco? We should use the visco not only for protecting the endothelium, but also protecting our speed. Our speed. If you just, you can say you have made 2 pieces, come out. Make a habit, come out, put a visco. Make 4 pieces, come out, put a visco. Then emulsify 2 pieces, come out, put a visco. What will happen? It is a 3 ml visco. What you are going to do? You use 1 ml, 2 ml you are throwing up. So price is same. So use that at 3 places when you are doing mature cataract, when you are doing nuclear cataract, and once you do that, what will happen? Second day your cornea will be not much, you can say SK, less SK, and patient is good. So it is always better to have a habit, and it is SOP. If there is a 2 pieces visco, 2 pieces eaten visco, and other 2 pieces visco if you put, then this will not happen. Don't I have? 1 minute. No, this is.
Nodding cataract.
Huh. Now this is the case I want to show you. One minute. Now no.
नहीं, इसके बाद.
इसके बाद okay. So you have seen this, the small part removed. I have put a visco and then I have removed the same case. So that part was remained. So I have put a visco, then I have brought it, and then I have completed this. So it is very easy, but you will have to take care of that. And now this is the another case I want to show you. Now what happens? This is a 55 years male, and you can say head nodding. Can you see the head nodding? Now in the head nodding, it is a mature cataract. See what happens when the patients are complicated patient, they never come in the early stage. They always come in the late stage. It means unless and until cataract is mature, they will not come to you. So before that, it means the cataract is mature, then and then they will come to you. And then what happens in such situation? We always think ye nikal jayega, and then that is a mature cataract. Now see what I am doing is, can you see this? So I have given peribulbar, and after giving the peribulbar, if you see the movements, so now we always say the pulse mode, then the another mode, that mode. Every pulse is done by the patient only. I am not doing any pulse. So it means now all the pulses, you have seen how I have done the cataract. The cataract was done by the patient, not me. I was holding the, you can say, tip, and that holding the tip has done everything. It means I have not done phacoemulsification in this patient. It was a patient who was knowing how to do the cataract, he did it. So that is the problem. It means how to do, you will have to do in between the movement. In between, or you will have to sedate. And once you have to sedate in this patient, then again there is a problem, because that sedation, what they will do and what they will not do. So now see here. Now again you will see what I am doing. So I want to see here, remove the cortex. I am trying to remove. See here, every time whenever I am trying to remove it, so patient is moving. See here. It means I want to remove the cortex, but patient will not listen to me. See here, I am putting the lens, but patient, the only thing is that what is stabilizing? Bimanual. Bimanual thing is stabilizing, and this intermittent sedation, see here now. So I am doing everything, but I have stabilized with one hand, and then I am doing it. It means in such situation, the patient will come when patient is blind, and then that time then they will say ki, they will we can say emotionally blackmail us ki now patient is blind, you should operate, and like that. And so the thing is that in such cases you can just be can say do it. And other thing is a microphthalmos. I don't know, but this coloboma with microphthalmos. So whenever now you see I was in JJ, later on I started practice. In every 1 week I get minimum 1 or 2 such type of cases. Less than microphthalmos, then coloboma of disc, coloboma of the macula, and patient will come. Now as patient will come, patient has got so many problems, and so you will have to take precaution when this patient comes there. So I have kept this case here, so that whenever the such patient comes, what precautions we can take. Now one by one we will come to see. Now see, I am doing it. Now here the pupil is not dilated adequately. Secondly, cornea is thick. Cornea is thick. See here I am going in, the cornea is thick cornea. So I have gone in this one. Now so what happens ki whenever now I am doing it, you will have to use the retentive cohesive ophthalmic visco devices, OAD. Why? Can aid in the dipping and over pressurizing the anterior chamber for the capsular rhexis. Otherwise rhexis is not possible, you can't do the rhexis. And the trypan blue stain, though patient is having the glow, use trypan blue. Now why trypan blue is used, why I am telling? Because I will tell you. Trypan blue is not only having the staining capacity, it is also having the capacity of weakening the capsule. Capsule is weakened. Now when? So if trypan blue is to be used, then what are the, you can say, properties of the trypan blue? Can anybody tell me? Trypan blue stains the capsule in 13 to 17 seconds. Stains. Trypan blue weakens the capsule from 55 to 65 seconds, not minutes, seconds. 55 to 65 seconds. Means what? If pediatric case is there, stain it above 55 seconds. If intumescent cataract is there, stain it above 55 seconds. Why? Here we require the other property of the trypan blue, and that property is weakening of the capsule. You will not get the irregular tears. In the, you can say, pediatric cataract, you will not get irregular tears if it is kept for 65 seconds. So it means trypan blue has two capacities, and so in such situation, you should use that trypan blue to weaken the capsule, and then you can do the capsular rhexis. Now see, I am doing the rhexis, and always the pupil is not dilated. And when the pupil is not dilated, you can see here the anterior chamber is, because eyeball is small eyeball, it is a shallower anterior chamber. Iris is closer to the internal wound of the stem because iris is near. Why? It is shallow, it is not behind, and so increasing the odds of this iris prolapse. The chances are iris will come out. Why? It is attached in front, not behind. Normally iris is attached behind, but here it is attached in front, and so it will come forward. And when it will come forward, it is there, iris is going to come. So in the normal cataract, iris prolapse is not much, but in this type of cataract, iris prolapse is much more. So again, you will have to now see, I am doing the hydrodissection, and see here. Once I am doing the hydrodissection, what has happened? The iris has came out. Now I am doing the phacoemulsification. So now you see the phaco I am doing, and always remember this iris, because I have touched the iris, because I have touched the iris, can you see the pupil? Can you see the pupil? Here is the pupil. It means this pupil was dilated up to here. But once the iris has came out, only once, and this only once trauma to the iris reduces the pupillary size. Now, can phenocane act here? Now when I have touched the iris, and my iris is now small, now intravitreal, this intracameral phenocane is there in the market. Can intracameral phenocane will act here or not? Yes, madam?
No, it will not act. In very few cases it is acting. In maximum cases it is not acting. In my experience.
Very true, madam. What madam says is very true. Though we feel that phenocane is going to help us when pupil is not dilated, always remember, when phenocane will not work, one, when you touch the iris, and because of touch of the iris pupil is constricted, it will not dilate by phenocane. Secondly, if you have given the peribulbar block and you are putting phenocane, it will not dilate. It means unless and until you put it first time, that will help you. Otherwise, this phenocane in between will never help. Now, how we are now behind phenocane? Because now we are going for the, can say, the cylindrical lenses, hai na? Toric. So in the toric we require the dilated pupil, and pupil is constricted while operating. In this situation, we require pupil should get dilated. But here pupil will never get dilated by the phenocane. So phenocane will not help in this situation. Now see, now I am doing it, but you can see how the small the pupil is. You can see this. The pupil is very smaller, and I am doing and now I have implanted the lens. Now the lens properly should go in the back, and if the lens is not going in the back, then that situation, it is very difficult to manage such cases, because if it is behind the iris, then patient will having so much irritation, and patient will be having the secondary glaucoma, because as it is a small eye, the chances of secondary glaucoma are very high. So that happens whenever you are doing this. I think our cases,
One more you can show na, the transparent sleeve and the change of the phaco.
that is hypermature. I will show one more case.
फिर की वो जो है ना जो transparent sleeve है, then watch that वो PL वाला वीडियो है. Expand करिए ना वहाँ पर.
Kara. Now this is the other cases. What? Now see here. The fibrosis in the center. Can you see this? Can you see this is the fibrosis in the center? It is a cortical cataract, and you can see what I am doing is.
Hypermature.
Huh?
My hypermature.
Can you see what I am doing is away from the, you can see fibrosis, I am catching the capsule and I am trying to do. Now see here. Now when I am trying to do here, always remember, don't go beyond that. That is the limit. That is the limit. Then you will have to go with the forceps, and with the forceps, then you will have to see here. Again can see I am going here, and with the forceps, you are very much away from that. Again rehold it, and once you rehold it, that is going to be larger, this one. So why it was larger? Because fibrosis of this one. And now here you see how you will do the.
Transparency.
Now here you will see. Now here always remember, whenever you are doing, easy to go for the horizontal chop. Why? Vertical chop in this situation will not work. And you see my tip. My tip is blunt in the tip. Tip is blunt. Chopper is a blunt tip chopper. I am using that, and there is no any buttress, there is no any support for that, and I am. Can you see this? Always remember, it should be 90 degree to the tip in such cases. So that 90 degree here again you will see the 90 degree is helping. And now what I was telling you, the last piece, the chopper movement should be minimum. See here, minimum. I have reduced every parameters. Can you see this? Can you see? Stand still. I have reduced, because that I have made my habit to do it. And once I have made my habit, then that is possible. See here now. This one I am doing. And sorry. See now. Okay. और एक बार आपको हाँ okay. Now see here. Can you see the fluid? Can you see the fluid here? So this is the fluid, and in the fluid I am doing the rexis here. So this is I am doing by the needle, and see here. So once I am doing it by the needle, so that I am trying to take it again by the needle only. So unless and until it goes in the periphery, you have seen I have taken over by the forceps. Now my question here is, when I am doing this, you will see this eccentric rexis, not center. But why it has happened? Because of the fibrosis of the capsule. If you want, after doing now here you will see it was a brown cataract now, and you can see now I am doing the chopping. Can you see this? My chopper is going in the periphery, in the edge of the nucleus. Can you see? And then after that, see here. Can you see this? Now I am breaking it, and you can see how hard it is. So it was seen, it was not hard before. Again you will see my tip has buried, and the nucleus is rotating because there is no support. And as the nucleus, again you will see I have done again I will see how this is going in, and you see this gone in again, gone in here, and then I made the pieces. So whenever I am making the pieces, I am going, you can see my tip is down, it is not up, it is slightly down, so that it goes in the substance of the nucleus. Unless and until it enters in the substance of the nucleus, that is not going to make the pieces. See here. So it is not going to make the pieces. So again, the small pieces I am making, and then the, see here, the, always remember when the last piece comes, here you see, stand still. So it means here my chopper movements are reduced, and only slightly I remove the this one and take it. This is a young patient, very young patient, and here I am doing the, can say the fluid. Can you see this? And this fluid can be just aspirated by the cystotome. Whatever the cystotome is there in your hand, you aspirate it, so that the pressure inside the nucleus is reduced. Now see, I am using the forceps, and in the forceps, always remember, in such situation, it is always better to use the forceps, and forceps will help you see doing the rhexis. So I have completed the rhexis. So once I have completed the rhexis, I am removing the capsule, and this nucleus is soft nucleus. It is not a hard nucleus. See, but can you see it is not, the nucleus is moving here and there. The other question you should ask here, that I am doing the chopping and my chopper is a sharp chopper here. Can you see this? So this is by mistake I am using the sharp chopper, because in such cases, if you use the sharp chopper, as you can't see the tip going behind the nucleus, you may in the horizontal, then you do the vertical chopping. That will help you while you are doing the vertical chopping. You will see here the pieces I am bringing here, and now see the last piece. Can you see this? In the last piece, you should be very slowly taking this, very slowly. It means you have reduced your speed in the last piece. Now see, this is the all fibrous area. I am doing it, and this, can you see this? Can you see what is happening? Can you see this? Here you see, I have teared here, and now you see what is going to happen. Now here, can you see this? Argentinian flap is happening. Argentinian flap is happening. Why it has happened? Now see, and then don't tear there. So what I am doing is wrong. Then tear on the other side, see here, and then cut on this side and complete. Now, now here you can see this flap. Can you see this flap? Can you see this flap? So when now I can do phaco or not, that is possible only by, you can say, this motility sign. So if that, again see this is the motility. Unless and this flap is moving, it means posterior capsule is not tear. If this flap stop moving, stop phacoemulsification. Don't do it. And if you do it, then that will go in the vitreous. So you will have to change everything and bring the nucleus by SICS. But still, always remember, you will have to keep your watch on this. And if this flap is moving, then there is no problem. You can go ahead and do it. Now here, you will see one thing. You can see the sleeve. Can you see the sleeve? The sleeve is whitish in color, transparent. And I am doing the cataract. This is a hypermature cataract. This is I am doing. This is from the, you can say, this is also from the very big company machine. And I am doing his. What mistake I am making? What mistake I am making? Can anybody tell me what is the mistake here I am making?
So you are not making.
Huh?
It should be embedded.
One.
The second thing is, sir, what is happening is that there is no followability. Means the phaco
Now,
machine
my
is
tip,
not able.
what madam has said is very true. But the, yes, madam, what we are telling?
Okay, actually the phaco tip should be able to hold the nucleus to itself, which is not happening here.
Basically, our tip should go inside, penetrate inside the nucleus. So that is why it penetrates inside the nucleus. Can anybody tell me? By what virtue? By what virtue the tip of the phaco tip penetrates inside the nucleus? Huh? Correct. One thing is there is a support of the posterior part that should be we always say that is a support. But to penetrate in, again, you do the drill, penetrate. So what is acting? Electric power. So like that here, the stroke length of the machine. So whenever you are purchasing the machine, you must know how much is the stroke length, and that stroke length is very important. Now in this, I am doing the phacoemulsification, and once I am doing the phacoemulsification, see here, the stroke length of this machine is less. I am doing upper, down, niche, upper, everything. It means by everything I am doing it, but still I am unable to penetrate in the this one. And what happens when you are see now, all these movements are happening, and what will happen to my heart? The heart will also like that. So I will get all type of pressures. So see now, fluttering of the heart. See, reducing my age by 1 month. See what happens, because see here, it is moving like this. Now when it is moving like this, then your age is going to reduce. So again I am trying, but lastly I got fed up and came out. Now see the sleeve. That was now here the white sleeve. Means I have changed the machine. It was possible because there are 13 machines in JJ, and because of that it was possible. Now see, same person, but how the machine is going in? It is a stroke length of the machine. So whenever you are purchasing, it may be a small company, you must know the stroke length is good, and then you should purchase it. So here again you will see the stroke length, and in that same nucleus, it is emulsified by the other machine. After you can say so many problems in that, and now I have emulsified it. See here again, I am emulsifying it. See here, completely emulsified. It means it is easy to emulsify if such type of nucleus is there also, and see the one piece is remained. I always say that the last piece. So whenever you are making, see here, it is very gradually you can remove the piece, and that will finish this one. And yes, this was possible just because the other machine was there. It means because of the stroke length, I was unable to do the hypermature cataract. So we have got 1 or 2 minutes. If anybody wants any question, or Ragini wants to say something.
No.
Okay. Anyone wants to ask any question, they can ask. Thank you, ma'am. Thank you very much. Thank you very much.
Thank you.
Thank you very much. Thank you very much.
Thank you, ma'am, for such active participation and making it an enjoyable session. Thank you, Narendra.
Very interactive class.
Thank you, ma'am.
Thank you.